Hi, my name is Ethan Korngold, and today I'll be talking about wiring to save the day for structural heart interventions. I'll show an illustrative case and I'll show several tips along the way. Here are my disclosures. So this patient is a 21-year-old man who had congenital unicuspid aortic valve with aortic stenosis, and 6 months prior he had undergone a Menugian root enlargement and mechanical AVR with a 23 millimeter onyx valve. Now the Menugian procedure, as you can see on the right, is a way of doing annular dilatation that involves cutting between the left and non-coronary cusps into the aortomitral curtain. The images during the procedure looked very good, and immediately post-procedure looked very good, but after the procedure he developed moderate to severe mitral regurgitation due to a perforated anterior mitral leaflet. Here's his TEE showing, this is a TEE several months after the surgery, showing moderate to severe mitral regurgitation, which was symptomatic through this perforation in the anterior mitral leaflet, and he had, importantly, no evidence whatsoever of endocarditis, had multiple blood cultures that were all negative and no symptoms of endocarditis. So the plan for him was to do a transeptal paravalvular leak closure in order to help stabilize his heart failure. So first tip is to minimize the number of curves that you're working with, and in general more telescoping catheters is not always better. So when I started doing these paravalvular leak closures, I would just add telescoping catheter after telescoping catheter, each with a curve. I would do an Agilis with a JR4 guide with the JR4 catheter inside it with an angled glide wire inside it with TUIs at every step of the way. And the problem is that it just becomes a little bit too cumbersome to keep track of all of the different curves and to use that to follow into the defect. So I think simpler is actually better in order to track into a defect. And at this point, my typical starting maneuver is to use an Agilis or a deflectable sheath with a JR4 or a vertebral catheter, so one curve, and then a straight glide wire. Tip number 2 is to use 3D echo for orientation. It can be very helpful with orientation, but I find that 3D echo is not quite good enough to wire, but it gets you in the neighborhood. Long view I think is very helpful to wire, and X-plane may be very useful. So I did the transeptal, went in with an Agilis sheath, and you can see on the 3D TE on the left panel there's the defect, the circular hole right in the middle of the image, and you can see the Agilis sheath wrapping around, which is sort of aiming a little bit askew, not quite at the defect. And then with some manipulation, as you can see on the right panel, I'm getting the end of the Agilis sheath sort of in the neighborhood of the defect. Tip number 3 for wiring is to focus on the defect and not on the wire or catheter. So there's a real tendency when starting out to try to track the catheter as the catheter moves, but it's much harder to track the catheter. I find it's much easier to show the defect as well as you can and then bring the wire or the catheter to the defect. And so this is what we did. We have images of the defect, and you can see I'm moving a wire to get it towards the defect. So rather than tracking the wire, I'm just keeping the defect fixed and bringing the wire to the defect. So more probing, more maneuvering, and getting closer. And again, more probing, more maneuvering. But one of the troubles in wiring these paravalvular leaks is that it's oftentimes hard to know where exactly is the end of the wire, where exactly is the end of the catheter. And specifically, are you seeing a tip of the catheter or are you seeing a cross section of the catheter? It's very difficult to determine that with echo. And so one tip that I'll use is I'll use a J wire or an angled glide wire, which has a very sort of known shape. And once you see that, either the J or the angle, you really know exactly where the tip of the wire is. And so what I'll do is I'll bring a J wire, just a regular coiled J wire, to the just extending out of the tip of the catheter, and then I'll use that to maneuver. As you can see in the bottom panel, you can see that J very clearly with echo, and then I'll bring the catheter over the J to where I want it to be, and then switch to the glide wire for the actual crossing. And so that's what I did in this case. So what was able to wire it with a glide wire advantage. Tip number 5 is the Safari wire. So this pre-shaped catheter, which was developed for TAVR, is really very useful for a lot of paravalvular leak closures. What I'll do is I'll cross the defect of the glide wire in a diagnostic catheter. The diagnostic catheters just have a very smooth transition over the wire. Then change the wire to a Safari wire. You have to be careful not to kick out the catheter as the Safari wire advances, and then upsides to a JR4 guide and sort of spin it through the defect. And so that's what I'm doing in this panel on the right. I've got the Safari wire placed, and then I'm spinning a JR4 guide through the defect. So in this case, I elected to close the anterior mitral leaflet defect with an Amplatz ductal occluder 2 with the 4mm by 4mm version, and you can see it then placing, really good images of it placing through the mitral leaflet defect. And after deployment, it's really sitting very, very nicely on the defect with just tiny residual flow, and most importantly, the function of the anterior mitral leaflet is preserved. The ADO2 device is very soft and floppy, and it did not overwhelm the function of the anterior mitral leaflet. I have 18-month follow-up on this patient. He's doing very, very well. Incredibly grateful to have avoided another operation. He has no mitral regurgitation on his echo, and his mitral valve is functioning very well with no gradient. So in summary, tips for wiring PVL: minimize the number of curves, use 3D TEE for orientation, focus your imaging on the leak, and then bring the catheter to the leak. Find the catheter tip and use the trick of a J-wire to help orient you and find the tip of the catheter, and then transition the guide over a Safari wire. Thanks very much. You can always reach out to me at ethan.korngold@providence.org or follow me on Twitter at EKGPDX. Thanks very much.